Okay, so we're going to start this second half of the session talking about the monthly summary data requirements. So remember, you've submitted that the monthly reporting plan. You've entered your events, and now it's the end of the month or the beginning of the next month, and you have to enter that monthly summary data. So there are some specific questions related to urinary tract surveillance that are applicable to you only if you are participating in UTI surveillance for the month. So remember this form from yesterday. This one denominator form can be used for any of the modules that you participate in. And if you're not participating in a particular module, just ignore the columns. But specific for long-term care, I have highlighted the questions that will apply. This form is optional. Again, this is a good form, especially if you're a manual facility or if you want to recruit some of your frontline staff members to help collect these data. And remember, only the aggregate, only the total numbers at the end of the month are what get entered into NHSN. So the form's only used if you want to collect those daily counts. And if you're collecting this information electronically, you may not need this form at all. You may have another method. The form is customizable, and we have instructions available if you need those. To add your monthly totals, you go back to your NHSN page on this left navigation. It's called Summary Data, and you just want to click Add. This is what's going to populate. So remember, your monthly summary data page is going to populate based on what? Your monthly reporting plan. So looking at this, if you're only reporting for the month for UTIs, then the only thing you're going to complete is this first section here called the HAI module. So everything with a red asterisk is required. So let's go through each of these questions. So the first one being your total resident days. This is exactly the same method that we talked about yesterday. You're looking at the total number of residents in your facility at the end of the month. So each day, you're going to count the number of residents and add that daily count to be your total for the month. You will have the option to use your electronic medical records if you'd like. You can leave the form at the desk for your frontline staff to help you out. You may also calculate based on your facility occupancy. So for example, if you're a 100-bed facility and you're 90% occupancy, then to calculate this, you would say that you had approximately 90 residents each day, and if there are 30 days in the month, that gives you 2,700 total resident days for that particular month. If you are participating in more than one module, when you enter the total resident days for one section, it will auto-populate in the remaining sections for you. So you only have to enter it once. And then urinary catheter days. So this allows you to calculate rates and look at your device utilization ratio based on urinary catheter status. For each day of the month, you want to count the number of residents in your facility that have an indwelling urinary device. I recommend that you do this count at the same time every day to be consistent. So for example, Mr. Smith has a Foley at 12, and if you do your count at 12, you're going to capture him. But if you do, let's say at 12:30, he had his Foley removed. If you do your count at 1, you won't capture him. So just try to come up with a routine. And this is a good place if you can recruit frontline staff, your CNAs or nurses on the floor to help you count these. But it just keep consistent so that your counts are consistent. And remember, you do not want to include any suprapubic catheters, straight in and out catheters in this count, or your condom catheters. And then you learned about the report no UTI events. Remember, this will be grayed out if you've reported UTI events for the month. But let's say for the month of March, your facility did really well and you had 0 UTIs. So on your monthly summary, this is going to have a red asterisk, which means that you did not report any UTI. So you just put a check mark confirming, yes, I performed surveillance. but I had nothing to report. And that just is a confirmation to NHSN that you did confirm that you performed that surveillance. New antibiotic starts for UTI indication. So this is the monthly total of all new prescriptions or orders for antibiotics given to residents suspected or diagnosed with a UTI. Now, you're going to count these antibiotic starts even if the infection being treated does not meet NHSN criteria for a UTI. So this is all of your residents who are treated for a UTI regardless if they meet any criteria. You also want to capture all new antibiotic starts regardless of how many days of therapy they receive. So Mr. Smith receives a Bactrim order on the 5th. He takes it one day, his susceptibility results come in, and the doctor changes it to a new antibiotic. So how many antibiotic starts would that be? 2. You do not want to include antibiotic courses started in another facility. So if your resident comes into your facility and has already taken an antibiotic for UTI, you don't want to add that unless your facility changes it and starts a new antibiotic. Number of urine cultures ordered. So these are the total number of new urine cultures ordered, regardless of whether that resident has a UTI or not. You're just counting the urine cultures ordered. Again, you do not want to include counts from other facilities, only from your facility. And I just want to say, so all of these questions I'm asking, because I know this is a lot of information today, all of these examples and details I'm giving you are in the table of instructions that accompany the forms. So if you forget, it's in the protocol too, but I find the table of instructions are just easier to read because it's in a table format and it's very nicely outlined. So if you forget what these mean, just go to the table of instructions, or you can send us an email too. We'll help you. But we have some FAQs on our website related to some of this stuff, some common questions that come in. So definitely use those resources to help you, and then use us as a resource as well. We love hearing from you. So as a review of what we talked about the first hour, your UTI surveillance must include all of your resident population facility-wide, and that includes you're looking for catheter-associated and non-catheter-associated UTIs. And to be considered catheter-associated, that catheter must be in place for a minimum of 2 calendar days, with the day of insertion being day 1, and in place at the time of event, so that onset, or when removed within 2 calendar days prior to, with the day of removal being day 1. Only submit a UTI event for a resident meeting NHSN UTI criteria. I didn't mention this, but I want to mention it now. Mixed flora is not considered an organism and cannot be submitted to NHSN as a pathogen. So let's say that the urine culture just grows mixed flora. Is that an acceptable urine culture for meeting the definition? No. Now, trick question, and this may or may not be on one of your case studies. If the resident has mixed flora and E. coli, does that meet the urine culture requirement? Think about that. So mixed flora, what does that mean? Does that mean it just has one organism in it? It means it has more than one, right? So if there's mixed flora plus an E. coli, then that's at least 3 organisms, right? So that would not meet. And then yeast cannot be reported as an organism for a UTI. But if the urine does have yeast plus 1 bacterium, you can still use that urine culture to meet. Date of event is the date when that first clinical evidence, so the signs or symptoms, appeared, or the date that the specimen was collected, whichever comes first. And I had a question over the break, well, what if these don't occur back to back? Because in a perfect world, the documentation would be great and these would occur on the same day or within a couple days, but that's not reality, right? So with these cases, you do have to make some clinical judgment. And I would say, we don't have a time frame for you to look at. And we purposely don't have a time frame for you to look at because we want to give you some flexibility. And we know that the documentation in long-term care facilities is just not the same as the documentation in acute care facilities. So we're still trying to figure out if we're going to apply a day time frame. But until then, we're looking at the data that you guys send and we're taking your feedback. And what we recommend is that you pick a time frame that you're comfortable with. For example, if all of this occurs within a 5-day period, do you consider that reasonable to say they all go together? So if the resident has dysuria on the 1st, and then let's say a specimen was collected on the 4th, do you consider that reasonable to say that meets UTI criteria? If you do, use that as your time frame and just be consistent. And so if you sent me a question and you said, gave me that scenario, I would say that does sound reasonable. If you gave me a scenario where the resident had dysuria on March 1st and then the urine culture on March 10th, no, I would say no. I would look for something closer together in time frame. And then infections should be attributed as an HAI for your facility if there's no evidence of incubation upon admission and that the onset occurs greater than 2 days after admission to your facility. And we just talked about this. There's really no set time frame, which one UTI. Oh, okay. So this is different. So the UTI protocol, just like we don't have a time frame when all of the criteria must be met, we don't give you a set specific time frame for identifying more than one UTI in a resident. So let's say Mr. Smith has a UTI that you reported on March 1st. He is treated and he gets better. And then on March 20th, it flares up again. So he's already completed treatment and now the symptoms come back. What would you do in that case? So think about that. So if you sent that to us, we would look at the whole picture, and what we're looking for is, did the UTI resolve? Did the resident receive treatment? Did the symptoms go away? And if yes to those, then it's likely this resident has a second reportable UTI. So there is some clinical judgment that you'll apply. And again, we are available. There is no right and wrong. And we're not the ones to tell you this is right or this is wrong. You have to figure out what you're comfortable with for your facility and your population. And we are here to help you with those clinical judgments if you need our help. We are more than happy to help you. All right, so let's talk about data quality. We talked about these pesky alerts yesterday, and this one is really bad. This person has 65 missing summary days. I mean, she must be on vacation. This is, again, what you don't want to see. When you come in on a Monday morning and you haven't had your coffee, or when you're getting ready to leave on a Friday afternoon and the DON says, oh, have you addressed all those alerts in NHSN? No. So you just want to be sure that you're addressing all these alerts so that your data are complete, because let's say that a scenario could happen on a Friday. You see that you have 65 missing summaries, but you're going to deal with it Monday, right? You can't deal with it today. Well, over the weekend, there was an outbreak of diarrhea in the nursing home. And so you come in Monday morning and the DON or the medical director has got a note on your door that says, call me. It's important. We're having an emergency meeting. I need to see the data. Guess what? You're not going to meet that requirement because it's going to take you a long time to enter those 65 missing summaries. So you just want to not let yourself get in that situation. And not to mention, recall, your memory recall is not going to be there. So remember, best practice, if you're able to, is to try to get each month done by the end of the following month. Some people are able to do this quarterly, and if you have a great memory like that, go for it. But I don't. I would forget everything if I waited 3 months. So again, there's some discretion, your judgment with that, but you'll kind of just figure out your routine of how you want to handle that. One of the most common alerts for UTI participation is that incomplete UTI event. Because unlike the lab ID event form, when you're submitting a lab ID, you have to answer all the questions before the form will let you save. But that's not the case with the UTI form. And the reason is because UTI surveillance requires a little more clinical decision making, a little more chart review. So we allow the users to save an incomplete UTI event, because we've had users tell us, well, I have the positive culture. I'd like to go ahead and enter that culture to remind me that I have to do the chart review. So the culture's entered, they save that as a reminder that they have to go back and enter the rest of the information, and then it's forgotten. So that is the most common reason for an alert for UTI. There we go. So if you see this incomplete event, which if you participate in UTI surveillance, you will eventually see this, I'm sure. You can click right into the number, and this is a good number, it's just 1. Or you can click up here if you want to see all of your alerts, organized for you. You just click alerts, and then it gives you the organized list. But if you click on that hyperlink, it's going to populate the one incomplete event. And all you need to do is just click on that event number, that hyperlink, and it's going to take you to your event. Okay, so what do you see wrong here? A lot, right? The main thing, the first thing, if I have a user email me and say, I don't know why the event's incomplete, the first thing I do when I look at your data is I look to see if the specific event is populated. If this is not populated, that tells me something's wrong. And most of the time, it's because the correct NHSN criteria has not been selected from the top. So what you would need to do here is review your data, your forms or the chart, and just select the specific criteria that this particular resident met. And let's say, so the resident had a positive urine culture. Let's say we found that. And acute dysuria. And then once you enter those two, that's going to meet the SUTI criteria. Because at the top up here, I said that there was not an indwelling device in place. So that is a flag to the NHSN system that it's looking for a SUTI, not a CA-SUTI, right? And so then it populated. So now I'm done. Everything's done. And then I'm going to click save. And once I do that, the event will disappear. It's gone. The next most common alert for UTI, for UTI and Lab ID, is this missing events. And this is a real easy fix as well. And what this means is that you have a monthly reporting plan in place. You indicated that you're going to be performing surveillance for UTI, but there were no UTIs entered for that particular month. So all you have to do there is go to your missing event line list and simply check report no events. If that's true, you want to verify that's true first. But if that's true, you truly did not have any events to report, you just put a check here, save, and it disappears off your alert. So this one's pretty easy. And then another, not as common, is just that you forgot to enter the summary data. You're missing the summary data. And this is a little more cumbersome. These are the ones that you don't want to get backed up, because this does require you to find information, right? This requires you to know your resident days and your catheter days. So you want to try to avoid letting this get backed up. But with this, you would get that line listing by clicking on your summary list or the particular alert. It's going to give you a line list here. And then you have to go through and click on each individual summary hyperlink, and it'll be highlighted yellow for you, and everything with a red asterisk just has to be filled in. And then save it. Okay, and then sometimes you'll have the incomplete summary data, and usually what that means is just that report no events needs to be reported here. And again, you just put a check mark in the box, and that was pretty easy. Just always remember to save before you exit out of that screen. Okay, you guys ready to test your knowledge? So the case studies you have are not related to this presentation. The case studies, if you picked up copies up front, that is for our 2 o'clock. So these may be in your slides though. I'm not sure. Okay, scenario 1. So let's take a look at your understanding of changes in mental. Oh no, I don't think I messed up. Okay. Which of the residents below fits NHSN CA-SUTI criteria? So you're going to select all that apply. A resident who is usually able to follow instructions has been unable to focus or pay attention to instructions for the last couple of days and has a WBC count of more than 20,000 leukocytes. B, a resident suddenly has fluctuating course, difficulty paying attention, and is not making sense during conversation, and has a WBC of greater than 14,000 leukocytes. C, a resident who recently begins to urinate in the bed. D, a resident who is usually able to follow instructions, has been unable to focus or pay attention to instructions for the last couple of days, and has a WBC count of more than 2,000 leukocytes. So it can be more than one. Okay, you ready? So it's A and B. And so A, the resident does meet criteria for acute change in mental status, right? And the resident has more than 20,000, which meets because the minimum is 14. So 20 does meet. And then B, the resident has a fluctuating course, difficulty paying attention, and the sudden, and also has leukocytes of greater than 14. So both of those meet. C does not meet because there's no accompanying leukocytosis. Remember, when you use mental status change, you also have to have that leukocytosis. You can't use mental status change alone. So if the resident also had leukocytosis, then you would want to do a little further investigation to see if that recent urination in the bed it would be incontinence maybe, and you would want to see if there's other criteria that meets. And then D does not meet because there's only 2,000 leukocytes, so it does not meet the leukocytosis definition. Okay, scenario 2. This is looking at the criteria for a CA-SUTI. Which of the following criteria would confirm a CA-SUTI? So you're going to pick one here. A, the resident's oral temperature is 100.2 Fahrenheit and the indwelling catheter specimen is positive for E. coli greater than 100,000. B, the resident has purulent discharge around the suprapubic catheter and the suprapubic catheter specimen is positive for E. coli greater than 100. C, the resident has a fluctuating change in mental status and a voided specimen positive for E. coli 100 colony forming units 4 days after the indwelling catheter was removed. And D, the resident has multiple oral temperatures of 98.2 degrees Fahrenheit, chills, sweating, and the indwelling catheter specimen is positive for E. coli greater than 100. Okay, you ready to see the answer? So the correct answer is A. Great job. So the resident has that temperature of 100.2 and the qualifying specimen. D is not correct because the oral temperature does not meet. Okay. Scenario 3, Mr. U is a resident of a long-term care facility and has a urinary catheter in place for 3 days for acute urinary retention. On day 3, he spikes a fever of 101 degrees Fahrenheit and has a cough with shortness of breath. The physician orders a urine culture and it comes back positive for greater than 100,000 of Pseudomonas aeruginosus and Candida albicans. Upon further workup, Mr. U is determined not to have any other symptoms that meet NHSN CA-SUTI criteria, but a chest x-ray does show infiltrates in the right upper lobe of the lung. Does he have a CA-SUTI? Yes, he does meet criteria for CA-SUTI. Or B, no, he does not meet criteria for CA-SUTI because the fever has another source of infection, respiratory infection. Okay. Well, the correct answer is A. So most of you did get that right. Didn't show up, but that's okay. So he does meet the criteria for CA-SUTI because he does have that indwelling urinary device, right? More than 2 days. He has the positive urine culture with at least one bacterium, and he has the fever. And remember, fever is nonspecific, so it may be applied to more than one infection cause. So even though he may have a respiratory tract infection, he also can be used, fever can also be used to meet that UTI. Let's take a look at what's going on with Mr. G. He has a voided urine culture that is positive for mixed flora, E. coli, and Candida glabrata, 100,000 colony forming units. During the medical record review, you read that 4 days earlier, Mr. G complained of burning during urination. You did not see documentation of an indwelling urinary device, but he does receive intermittent catheterization for urinary retention. Does Mr. G meet the NHSN UTI criteria? A, yes, he meets NHSN criteria for a SUTI. B, no, he does not meet NHSN criteria for a UTI. C, yes, he meets NHSN criteria for CA-SUTI. Or D, yes, he meets NHSN criteria for a booty. You guys definitely have this one. Correct answer is yes. He does not meet the UTI criteria for at all. Why? Right. He had that mixed flora. So he had plus other organisms. So he had more than 2 organisms growing in that urine culture. All right. Let's take a look at Mr. S. Mr. S is a 90-year-old resident in the facility. He has a history of multiple medical issues. On 3/3/18, blood, urine, and wound cultures were collected. And here's his lab report here. So on 3/5, this is what was reported. Blood culture positive for greater than 100,000 of Streptococcus pyogenes. A urine culture was positive for greater than 100,000 of Streptococcus pyogenes. And then a wound culture was also positive for Pseudomonas aeruginosus, 100,000 colony-forming units. Mr. S does have an indwelling catheter that has been in place for the past 10 days, but you do not find any documentation indicating signs or symptoms of a UTI in the previous 7 days. Uh-oh. So does Mr. S have a SUTI? Yes, because he had a positive urine culture plus a positive blood culture with the same organism. Yes, because he had a urine culture positive for more than 100,000 colony-forming units of strep pyogenes. C, no, because he does not have any localizing signs or symptoms of a UTI. Or D, just not sure. So you're looking for a SUTI. Does he have a SUTI? So does he have a symptomatic UTI? You guys are smart. So most of you got this correct. No, he does not have localizing signs of a UTI, so he does not meet SUTI criteria, right? But there's more. Does Mr. S have another NHSN defined UTI? So A, yes, he has an ABUTI because he had a positive urine culture and a positive blood culture with the same organism and no documented signs or symptoms. Or B, no, because the staff probably forgot to document the signs and symptoms for a UTI. I mean, that's not, I guess, that unrealistic. Excellent. I thought for sure we were going to have some jokesters in here. Good job. Okay, so we had that positive blood culture, that positive urine culture with that matching bacteria, and there were no documented signs or symptoms. And this is, could be a good example of, yes, the documentation is lacking for surveillance, but this may be a situation where maybe he was examined by the nurse practitioner or the physician, and they did recognize that there was something, there was something going on with the resident and treated the resident. So it could be a case where the resident truly did not have a SUTI because there wasn't one there, or just that the documentation was lacking. Could be either or, but you want to stick with the surveillance definitions because the surveillance definitions, when as consistently applied, and when they don't match up with your treatment. So if you get your quarterly report and you have 5 UTIs, but you have 20 treatments, because you're going to see that, then you're going to wonder, why do we have that huge discrepancy? Is it a problem with our documentation, or is it a problem with over-treating UTIs? And it's going to be a flag for you to do further investigation. Let's take a look at Ms. R. Ms. R. Day 1. Ms. R had an indwelling urinary catheter inserted for a bladder outlet obstruction. Day 2, the indwelling urinary catheter remains in place. Day 3, the resident's indwelling urinary catheter remains in place. And the resident had a single oral temperature of 100.2 degrees Fahrenheit, and a urine culture was collected. Day 4, the indwelling catheter is still in place. No symptoms are documented. And day 5, the urine culture was positive for Candida glabrata, 100,000 colony-forming units. Does Ms. R have a CA-SUTI? Excellent. So you guys know this one. No. Very good. So again, at least one organism in that urine culture must be positive for bacteria. Okay, scenario 8. If your facility is interested in reporting UTI events to NHSN, which module would you select on the monthly reporting plan? A, the Lab ID event module. B, the Prevention Process Measures module. C, Healthcare Associated Infections module. Or D, the Dialysis module. There you go. Isn't it nice to get some easy ones sometimes? Good job. I know this 13% is kidding me. That's not in this room. It must be the web streamers. They had to go on break while we were talking about that. Good job. Yep. There we go. Great job. So it's the Healthcare Associated Infection module, which currently has the availability for UTI surveillance. And what's coming in the future? Respiratory tract, and then following that will be skin and soft tissue, and then we're just going to keep growing. Scenario 9. This is a true or false. For NHSN UTI event reporting, a facility may choose to report catheter-associated UTIs only. Excellent. So that is false. You have to look for all UTIs. And that is different from acute care because some of you, I'm sure, probably do surveillance for acute care as well. In acute care, they're really looking at those device-associated infections. But the difference is, as Nicola pointed out in her prevalence survey, is that a majority of the UTIs in long-term care facilities are non-catheter associated, right? Because these, especially in nursing homes, these are the homes for these people. So they don't walk around with a catheter hanging out their bladder, right? So they're more prone to getting non-catheter associated UTIs, which is why we look at both, because we do want to know if they have a catheter associated. So that's why it's so important to look for both of those in the long-term care population. Scenario 10. When entering the monthly total for new antibiotic starts, which residents are included? A, all residents who had new prescriptions or orders for antibiotics for suspected or diagnosed UTI. B, only residents who received antibiotic orders and met NHSN criteria for a UTI event. Or C, only residents who had a positive urine culture. So remember, this is the question on your summary data form at the end of the month that you're answering. So how many total in that month of your residents had a new order for antibiotics for a suspected or diagnosed UTI? Okay. You guys got it. So the correct answer is A. So you're only looking at residents who had a new order. It does not matter if the resident met criteria. So you're only looking at those orders for diagnosed or suspected. Good job. Oh no, the answer. I don't know what happened. Well, we'll do this one anyways. You guys get a freebie. When entering the monthly total for number of urine culture, no, this is the one is this the one we just did? I'm so confused. Oh my goodness. Okay, so when entering the monthly total for the number of urine cultures ordered, which residents are included? A, urine cultures for residents who met NHSN criteria, no. Or B, which really looks good, doesn't it? Only new urine cultures ordered for a resident regardless of whether that resident has a UTI meeting UTI criteria. Or C, urine cultures ordered for residents with documentation. So the correct answer is B. You're looking at all urine cultures independent of the meeting the NHSN criteria. Now this is so weird. What? This is not happening. You guys need a lunch break. Yeah. Some weird stuff is happening up here. Okay, there we go. Okay. I know you guys are smart and are kidding with me. Okay, so there we go. All right, this one. All right. So scenario 12, define date of event for a UTI. So it's A, the date the urine culture was collected. B, the date when the first clinical evidence, so your signs or symptoms of infection appeared, or the date the specimen used to meet the infection criteria was collected, whichever comes first. C, date urine culture is ordered. D, the date the event is submitted to NHSN. 100% of you are 100% correct. Good job. I find when taking standardized tests is usually the answer that is really detailed is usually the correct answer. Okay. So it's whichever comes first. I think of the chicken and the egg. Which came first? I don't know. So whatever happens first is considered your date of event. Okay, so scenario 13, if DHQP nursing home is interested in submitting UTI data to NHSN only for the dementia unit, which locations must be selected when setting up the NHSN monthly reporting plan? A, the dementia unit if it has been mapped in the NHSN as a resident care location. B, facility-wide inpatient or FAC-wide-in must be selected on the NHSN monthly reporting plan, and UTI surveillance must be performed for all resident care locations. Or C, facility-wide inpatient must be selected on the monthly reporting plan, but the facility can limit their UTI surveillance to include only the dementia unit. Yeah, I know that's a joke. So think about that. What is that saying? Say what you do and do what you say. Is that a saying? I've heard that. Say what you do. Is that right? Say what you're going to do and do what you said you're going to do. Anyway, I think that's something. I've heard that somewhere. But anyway, that applies here. If it's new to you, if you haven't heard it, that does apply here. All right. Good job. So whatever, you have to select facility-wide inpatient, and then you should be looking for those infections. Now, along the same lines, you will be able to, so if you just wanted it in your analysis just to see how many UTIs were in the dementia unit, you will be able to stratify your data to look at the UTIs reported just for that unit. So you can do that for any of your units, because even though you're reporting FAC-wide and you're indicating that on your monthly reporting plan, but remember, when you're reporting your events, that drop down that asks for the location of the resident. So that by selecting that, you are able to look at the risk in each individual unit as well as a facility-wide level if you want to. Okay. So remember how I said it's important to do your counts at the same time every day just for consistency. So here we have the indwelling urinary catheter count at 12 noon on May 2nd. So how many catheter days do we have on May 2nd at 12 noon? Those are some hints. And I'm keeping it here just because when I go to the poll everywhere slide, you can't see this, the screen. I mean, the picture. I know that math is not the strong point for many nurses, so I'm going to give you extra time. I'm a nurse, so I can say that. I remember in nursing school, all of the professors would say, "Oh, you have to be good in math to be a nurse." I mean, nursing is all about the math, the medication math. And I'm like, "Oh, Lord, I almost dropped out of nursing school." But thank goodness they were wrong. Okay, let's see what you guys have here. Very good. All right, you guys are right on the money. So it's D, and let's see. So here you have resident in room 101 has an indwelling catheter. 104 has a Foley indwelling catheter. And then 106 has an indwelling catheter. And the reason, did anyone count 108, Mr. Sonny? Why? See, he was placed at 2 p.m. So this is just kind of show you a good example of, counting consistently. And one thing that I would advise you, if you are going to ask your CNAs or other staff to do the counts for you, just give them a little education and remind them that condom caths are not counted, suprapubic caths are not counted, just so that they know, because that really is an area of confusion for some people, especially the suprapubic catheters. Okay, you guys are going to have an early lunch. So I want to open it up for questions. If you have questions.
So I have two questions.
Okay.
So one, I didn't notice anywhere that with the catheters and getting your specimens, you talk about the length of time the catheter was in, 14 days or more versus that. So I don't know, is that still applying in the NHSN system?
That is a great question. That statement is in our protocol. And actually, I'm wondering if I removed that because we had some confusion, people thinking that we were advising them to replace catheters. And we definitely, that is against, I think, the guidelines out there to replace catheters. Basically, when we had that, what we were advising is, if that catheter has been in there in a long time and it's crusty and gross and growing yucky stuff in the bag, then you're not going to get a good specimen, right? If you take a specimen out of that bag, and it's going to be colonization. And so that's where we were trying to make that point, is take that in consideration when you're getting your urine specimen, if you're taking it from that indwelling catheter. So if you've got crusty and gross stuff growing in the bag, and you're wanting to get a good urine specimen, especially if it's going to dictate clinical treatment decisions, then yeah, you probably do want to replace that catheter so that you can get a good specimen. But we definitely don't advocate the routine replacement of those catheters.
Right. So I guess, I was always taught that the rationale behind that was because within 3 to 4 days of placing the catheter, you get biofilm.
Oh, definitely.
And everything else.
Mm-hmm.
So if you don't replace it, if it's been in place more than short term, you're risking more contamination.
Yes.
Of your specimen. So
you definitely are, and you want to take that in consideration with the overall picture of the resident. So if you just have that positive urine culture and nothing else going on, or maybe just a slight fever, you want to take that into consideration when you're making those determinations. And then you also want to base it on what is the practice in your facility, and maybe what is the physician or the nurse practitioner advising to do, and how important is it to get that close to sterile as you can get, and you just kind of have to weigh that in. Well, what risk are we putting the resident, increased risk, by changing that catheter? Because we do know that anytime a catheter is inserted or changed is putting increased risk on that resident. So you just have to weigh that in and go according to your facility practices and policies.
Okay, and the other one is just clarification. So on your slide, for confusion. Your slide talked about new or worsening. And then on the chart or table, it just says the word new. So if I have a pleasantly demented dementia patient, and now all of a sudden there's that acute, increased confusion. So on the slide, I would say yes, but in the book, it doesn't say new or worsening. It just says new.
No. Yep. So, I think that's just kind of a twisting of words. So, again, you would want to use your assessment. And if it is something new for that resident and the resident has leukocytosis, then I think that you have a case to report that as a UTI. But again, base it on your practices in your facility, your documentation practices, and what, the overall clinical picture. But I would say if it's worsening to a point where it's acutely new, behavior from the baseline or the normal behavior for that resident, that would definitely be considered.
Thank you.
Definitely. You're welcome. Another question.
Good morning.
Hi.
Hi. You may have covered this in scenario 422. I'm not sure.
Oh, wait until 2 o'clock.
If you did, I'm
we
sorry.
have 422 more.
So what if you have a UTI that's also an MDRO and you've elected just to enter UTIs or just MDROs or maybe enter both? So where do you enter it, or do you enter it at all?
That is a perfect question. Like, I could have paid you to ask that question.
I'm available.
You
For payment,
definitely,
I'm sorry.
you would report both. You would report both. So let's say that you have a patient who has MRSA in the urine and meets UTI criteria. So you would report that UTI with the MRSA. And then let's say you do MRSA lab ID event reporting. And if that met the non-duplicate, so if that was the first urine specimen of the month for that resident, then yes, you would report both. So that'd be 2 separate events. That's a great question. I'm glad that you mentioned that, because I did not put that in any of my case studies, but I will for next year. Does everybody understand that, what the question was? So if you have a resident who has an MDRO that you include in your surveillance plus a UTI, then you would report those as 2 separate events. So because one falls under that HAI module and then one falls under the lab ID event module. Hi.
Hi. On the new antibiotic starts, on that denominators page, so it says, do not include antibiotic courses started in another healthcare facility prior to the resident's admission or readmission back to your facility, even if the resident continues to take the antibiotic while in the facility. So clarify my understanding, if we sent them to the emergency department, they write an antibiotic, and we're going to give it.
So that's correct. You are correct. You do not. So if the patient goes to the emergency department and they start an antibiotic, then that is a good question, because we don't address that. I know we count other things for the emergency department, so I can see why you're asking that. But I would say I'm going to look for clarification to make sure we don't address that. But I would say off the top of my head, no, you would not report it, because we have that criteria set up specifically to say we're started from another facility. But I will let me just clarify and make sure, and I'll address it again today at 2 when we do our case studies. That's a good question. Any other questions? Okay.